Greetings, PCLP scholars. I am Dr. David Norris, an Associate Professor of Family Medicine at the University of Mississippi Medical Center in Jackson, and it is my pleasure to introduce this 2014 Primary Care Leadership Program Colloquium entitled Exploring Diabetes. Along with hypertension, dyslipidemia, smoking, and obesity, diabetes is one of the major risk factors for coronary artery disease and is a leading cause of preventable blindness, renal failure, and limb amputations. Affecting nearly 26 million American adults, the costs associated with diabetes and its complications are estimated to rise above $3 billion over the next decade. And this number only represents the direct cost associated with treating the disease and complications. It does not include economic losses such as time off work and disability, nor does it include human factors such as stress and depression that are often associated with chronic diseases. The management of diabetes is particularly complicated, with primary care providers responsible not only for managing blood glucose values, but also providing and coordinating a plethora of preventive services such as foot and eye examinations and vaccinations. With patient encounter times averaging between 15 to 20 minutes each, physicians may become overwhelmed trying to ensure all recommendations are followed. And patients may become overwhelmed trying to understand their disease process as well as its treatment goals and techniques. The scholars presenting in this colloquium have developed a number of projects aimed at improving diabetes care by empowering patients through education, optimizing provider time utilization, and involving multidisciplinary team members. I would like to congratulate all of the scholars presenting on the quality of their work in such an important area of care for patients nationwide. And now, without further ado, we will begin our presentations.
My name is Centara Bradley, a second-year medical student at Meharry Medical College in Nashville, Tennessee. The title of my research project is Diabetes and Depression, Determining the Coexistence in Primary Care. The research was conducted at Matthew Walker Comprehensive Health Center here in Nashville, Tennessee. Diabetes is a chronic metabolic disorder that is of growing concern in the healthcare field. Approximately 15,000 people are diagnosed with type 1 diabetes each year. 87.3 million people are diagnosed as pre-diabetic. A number of comorbidities exist with diabetes, including hypertension, stroke, and hyperlipidemia. Included among these is also depression. Lifestyle and education interventions, however, have been shown to improve not only weight and fasting blood glucose among diabetics, but also have been shown to improve depressive symptoms. Therefore, I wanted to administer the PHQ-9, or the Patient Health Questionnaire 9, to both diabetic and non-diabetic patients in order to determine if depression is indeed an underlying comorbidity among the diabetic patients in one of Nashville's underserved communities. I hypothesized that having diabetic patients participate in educational intervention would significantly decrease the patient's depression rating after 1 month. PHQ surveys were distributed to patients visiting the adult medicine clinic in order to test my hypothesis. In addition to the diabetic patients receiving the PHQ-9, they also received counseling about diabetes, about weight management, and about their glycemic index. Non-diabetic patients were given the PHQ-9 and told how the questionnaire would be used. At the project's conclusion, I found that the mean PHQ score of diabetics and non-diabetics did not significantly differ from one another at initial PHQ administration. However, the average PHQ score of non-diabetic males was significantly higher than the average PHQ score of non-diabetic females. The diabetic's average PHQ score was significantly lower than the non-diabetics at 1 month follow-up. There was a trend towards significance such that the non-diabetics with triglyceride levels greater than 150 milligrams per deciliter were almost The PHQ scores of these individuals was almost higher, significantly higher than the non-diabetics with triglyceride levels lower than 150 milligrams per deciliter. Additionally, there was a trend towards significance for the PHQ scores of overweight non-diabetics and obese non-diabetics, such that the obese non-diabetic PHQ score trended towards being significantly different than the overweight non-diabetic. Therefore, I recommend that Matthew Walker continue screening for depression and follow up with patients who do show signs of depression. Additionally, they should consider designing exercise classes as a form of stress and weight management and to improve patients' mental status and depressive symptoms. Lastly, the clinic should consider incorporating education into all patients' care so that the patients can better manage their health. Thank you for your time.
Hello, my name is Erin Huff. I'm a second-year student at Morehouse School of Medicine. My site placement was Matthew Walker Comprehensive Health Center in Nashville, Tennessee, and my project was tackling diabetes through nutrition education. My objective was to increase the knowledge of Matthew Walker patients with diabetes in order for them to successfully manage their disease through good nutrition and a healthier lifestyle by the end of the program. This was measured by pre-tests and post-tests. My method was doing a pre-survey before I handed them my nutrition booklet, and after 2 weeks of them having the booklet, I conducted a post-survey through phone call. My key findings were that the frequency of fruits, vegetables, and amount of water consumed was increased. Also, the frequency of junk foods consumed decreased. My recommendations to the center were for them to have diabetes nutrition information available to diabetic patients who may be struggling with keeping their blood glucose under control, and also possibly extending the diabetes clinic hours to accommodate patients who may not be able to make it on Thursday mornings for the extra education that they provide then. Thank you very much.
My name is Trang Liu, and I'm a recent graduate of the University of California Physician Assistant Program. I did my leadership training at St. John's Well Child and Family Center in Los Angeles, California. St. John's offers free weekly diabetes health education class to their patients. My goal was to find out if their classes were making improvements in the health of the attendees and to learn of the attendees' attitudes towards the class. The results shows that the feedback from the survey showed that all the attendees enjoyed the class and have found it to be very insightful in learning about diabetes and how to take care of their health. Attendees collectively had an average 5% decrease in their fasting blood sugar over a 5-month period of attending classes. It is likely that the health class had been providing them the tools and knowledge to help them create a healthy meal plan and be compliant with the treatment plan. The diabetic attendees of the class managed to avoid gaining excessive weight, only an insignificant average group weight gain of 0.3 pounds, about the weight of a large apple. It is suspected that if these patients did not have other debilitating chronic diseases such as osteoarthritis, that prevented them from being fully physically active, they would be able to put in the effort to lose considerable amount of weight. This specific project topic has the potential to provide more accurate and useful information regarding health education and its impact on diabetes. For future continuation of this project, improvements could be made to obtain a larger sample size with equal numbers of subjects in the treatment group, which is the attendees of the diabetes class, and the control groups, which are the non-attendees. This would help in yielding more accurate results of the differences in health knowledge, fasting blood sugar levels, and weight changes between the two groups. In addition to documenting weekly fasting blood sugar levels, it is important to also collect hemoglobin A1C values of each participant. Hemoglobin A1C is a more reliable blood test to measure the actual average blood sugar levels in the previous 3 months, which is a great marker to monitor the control of blood sugar. Lastly, in order to produce more solid information to observe a trend in the changes in physiological data, such as blood sugar levels and weight measurements, and health knowledge, the duration of the research project should last a minimum of 1 year. The end.
Hi, my name is Jade Sanders, and this upcoming fall, I will be a second-year student in the UCLA Prime Charles R. Drew UCLA Medical Education Program. This program is a 5-year dual-degree program within the David Geffen School of Medicine at UCLA that is geared towards fostering future physicians who are interested in practicing urban underserved medicine. As a 2014 GE NMF Primary Care Leadership Program Scholar this summer, I was placed at St. John's Well Child and Family Center, located in South Los Angeles. St. John's is a federally qualified health center that services the healthcare needs of much of the South Los Angeles population. As type 2 diabetes is very prevalent within this population, St. John's has developed weekly group care diabetes classes 2 years ago. These classes take place at its 3 large clinic sites, Williams, Magnolia, and Compton. As a part of this opportunity, I was able to become integrated with the weekly group care classes at St. John's William Clinic, where I developed my independent service learning project. My experiences within this class influenced me to take a more in-depth look at the impact of these services. The American Diabetes Association recommends that all patients with type 2 diabetes see their primary care physician on a quarterly basis and obtain annual visits with an ophthalmologist and podiatrist. However, as many of the diabetic patients seen at St. John's Well Child and Family Center will remain uninsured in spite of the Affordable Care Act, their access to care is limited. As a federally qualified health center, St. John's is still faced with the task of managing the care of these patients despite limited funding resources. Thus, the weekly group care classes have been used as supplementary management. However, throughout the 2-year existence of these weekly group care classes, no long-term evaluation has taken place. Thus, my project sought to begin a prospective preliminary analysis of the Williams Clinic weekly diabetes group care class to determine its cost-effectiveness and social return on investment. In the long term, it seeks to delineate the biophysical benefits of group care for the management of a low-income Latino type 2 diabetes population, quantify the costs associated with maintaining weekly group care, and determine its qualitative outcomes in managing this particular subset of type 2 diabetic patients in comparison to standard care alone. Preliminary 2-month data reveals a decrease in the number of patients with hemoglobin A1C values greater than 7% and non-fasting blood glucose values greater than 180 milligrams per deciliter amongst those patients who have attended at least one group care class from May 7, 2014 to July 2, 2014. While no substantial recommendations can be made from this 2-month data, subsequent work hopes to bolster study sample size and review referral and hospitalization rates as outcomes to provide greater insight into the effectiveness of these weekly group care classes in the management of St. John's type 2 diabetic population.
Hello, my name is Sotivi Van. My GE National Medical Fellowship Primary Care Leadership site placement was at Jackson Hines Comprehensive Health Center in Jackson, Mississippi. My project is on evaluating the effectiveness of patient education and disease management by a clinical pharmacist in diabetes. Diabetes is a serious and expensive disease in America. Its treatment and related costs was 10% of national healthcare spending in 2010. Diabetes is the leading cause of adult blindness, kidney failures, and non-traumatic lower limb amputations. However, if properly managed, most of the diabetes complications can be avoided or delayed. With primary care physicians nationally overburdened with patients and limited in visit time, patient educators can fill in the gap for diabetes education and counseling. The purpose of patient education is to improve glycemic control, delay or avoid diabetes-related complications, increase quality of life, and keep treatment costs effective. Patient education and counseling empowers patients with knowledge to better manage and control their disease. The objective of this project is to evaluate the effectiveness of diabetes education and counseling by a clinical pharmacist in terms of improving hemoglobin A1C outcome and patient satisfaction and knowledge. The A1C record of the patients before and after receiving the extra diabetes education were retrieved from the Jackson Hines EHR system. Surveys were conducted to measure patient knowledge and satisfaction on patients who received the extra diabetes education and on patients who did not receive the extra diabetes education at Jackson Hines Main and South Clinic. The results showed that patients had increasing A1C on average before receiving the diabetes education and counseling, but after receiving the service, these diabetic patients' A1C decreased on average. Therefore, glycemic control improved after receiving diabetes education and counseling by the pharmacist. Patients with extra diabetes education from the clinical pharmacist had slightly higher satisfaction and diabetes knowledge compared to patients without the extra diabetes education. However, the sample size was small and the results were not statistically significant. Based on what I observed, I would recommend increasing the availability and awareness of diabetes education to patients and physicians. Encourage healthcare providers to help form peer diabetes support groups and follow the American Diabetes Association recommendations on how often A1C testing should be performed to better monitor and record patients' glycemic control over time.